the history of sleep apnea as a model for cure of chronic disease in sleep. And the second was talk about research activities. So let's see, how do quick, name an emergent sleep disorder. What's an emergency? Sleep disorder, emergency. We need a sleep doctor.
Strohl syndrome. What?
Well, what's that? Strohl. It is. Huh? What, stunned silence? You've been here for 2 months and you haven't seen an emergency yet?
Not yet.
OHS.
OHS. It's not bad.
I just had a consult for cataplexy, seizure. I mean, the patient is being monitored for seizure episodes and things that the episodes are going to happen.
Yeah, and these were by board certified neurophysiologists. Right? Okay, next. What else? Anything else? Sushil, you got some ideas?
You got me.
No, no, I mean, see, that's here. So here's what I came up with. Let's see if I can get PAP for severe hypoventilation, right? So you put it up. So, but is that really sleep, or is that, you know, oh, I'm a pulmonary critical care, I can do non-invasive ventilation? That's not sleep, except when it's an outpatient, right? Except when it's near death involving OSA, SUDA or VTAC. So sometimes I'll find an obstructive sleep apnea. It's pretty severe. It produces a seizure. Produces very uncommon. I was involved in some of the SUDA things. Status, cataplex. So that's where, you know, people have prolonged cataplexy, and it's mostly, it can occur spontaneously, but it can occur after discontinuation of chronic clomipramide, and they'll come in and people won't know what it's all about. These are other ideas. PDS, school bus driver, nuclear plant operator, you know.
3 Mile Island was.
I don't want to see somebody coming at me doing that. Severe RBD, that is, that people get out their arthritis. But even an RBD or even false sleep car crashes, and they come into the ER and they have to get stitched up and all that, they usually get sent home, pat on the head, saying, you know, go see your primary care. You just got up and smash yourself on your dresser, broke a beer, lacerated.
Got a picture of that.
Yeah,
Patient.
right.
18 stitches.
Right. And then suicidality and insomnia. That's something that I think that Kamal is looking at over there. Is the people who have severe insomnia and suicidality, and he doesn't really understand exactly whom you could tell a psychiatrist to say, gee, you know, you should treat this insomnia and pick a drug that works pretty well. He likes mirtazapine because he has experience with it. But there's no randomized control trials for that sort of thing. But people come in actively suicide. Okay. So here lies the problem. We have few heroic situations, right? I mean, if you're a cardiologist, you say, oh, I'm just itching to get in there and get that left vein open. I'm a pulmonary person. I got to intubate. I got to treat sepsis. I got to do this sort of stuff. But that's that we take care of very few. So I'm going to talk a little bit about the history of obstructive sleep apnea, its management, and just to give some context of what we can treat in terms of chronic illnesses. So the definition of this is a syndrome, and we have to. That was the original intent of this, 1970s, 1980s. And it was symptoms, and you had certain symptoms. Now we expanded it to whether or not you're just a little short of breath during the day. Now we've expanded it to sort of say, oh, you got a little inattention here, and you're just not sleeping really well, and all that. But the way it used to be that you would wake time sleep is cognitive decline, inattention, and normal sleep behaviors of snoring, gasping, and restless sleep. Then you have an apnea hypopnea index greater than 5, right? Greater than 5. Probably all you people have an apnea hypopnea index greater than 5 during no sleep. I bet the women do. You know, that's pretty low bar, right? But it has to be accompanied by symptoms. And then the other is resolution of symptoms without therapy. And even the idea that if you have an AHI between 5 and 15, that studies in 1993 that were done here, other places have the same sort of thing, showed that if you had symptoms and you treated with CPAP at that time versus breathe right strips, just to have something on your nose, the 7% of people with breathe right strips had resolution of their sleepiness subjectively and subjectively, and an improvement in their snoring. And 40% of people with CPAP, leaving 60% not having really been touched. So did they have that syndrome, or was it true and unrelated? And the same thing is that we don't have really a TSH value for sleep. So it's still clinical. So why bother? Why bother? And this has always been, this comes up all the time. Impairs health, automobile accidents. It's the leading cause of fall asleep car crashes due to a medical condition. The most common car crashes, sleepiness is sleep deprivation. Cardiovascular risk plus minus after hypertension. We don't know if it does that. We don't know whether or not it just amplifies it or it's a happy traveler with heart disease. And quality of life is something people really have noticed. And the treatable, that is randomized controlled trials, show it improves sleepiness and quality of life and reduces blood pressure. And the rest, Strohl has been in these studies. We're pretty disappointed that we haven't been able to target something. Say we treat bad things with sleep apnea, we treat other bad things. I mean, we can improve quality of life, reduce AHI. What's its outcome? What's its way of doing this? So it's a chronic disease. It's not an acute disease. I mean, I don't, if it is an acute disease, it's usually because of some sort of trauma to the upper airway, some sort of recognition that it's sleep apnea because they haven't goiter, something like that comes up, or some narrowing that comes up, some sort of. Have you ever heard of acute obstructive sleep apnea? Improving outcome using CPAP as an example and management in the future. So from 1964 to 1991, so 64 to 80 was the focus on human sleep physiology, a few sleep laboratories. Based on case reports for case series, sleep apnea was considered unusual, rare. Active sleep centers were doing 2 and 4 sleep studies a month. And they do it once a week. Why? Because their technicians had to stay up all night. And that was the same EEG technicians that did it. And that was between up until about 1980. There were some places like in Denver, they had been in Johns Hopkins as well, where fellows would stay up and measure things of that sort. I did my sleep studies when I was a fellow. I could take all the equipment that was in the physiology of that, take it to some bedroom-like place, which included putting a mattress on our desks that we used during the day and having people sleep there. Sort of doing. And so, you know, there were no treatments, and tracheostomy was the primary thinking about it, and you thought about it a lot. So CPAP and uveal palatal came in 1981. It was creation of clinics, definition of training, and it was a really good specialty. People started to take notice of it, and industry started to take notice of it because they thought there was a lot of people that might use it. So the CPAP industry in particular, so that was Respironics in the United States. First had the first mask. It was remade from something used for exercise, measuring your exercise, full face mask, exercise rather than mouthpiece. use nose clips, and they cut it down, this, that, they were pretty clunky. Before 1986, though, you had to make your own CPAP mask, and I was making it over the making a mold of a person's nose, and then on that mold, I would put plastic melted on the shape of their nose, and cut it out, and put 2 holes in it, glue things on it. And I would have patients waiting for me on Monday morning to fix their mask because you guys got really easy. So the case management was this sort of linear progression: interview, assess, test, and treat. At each point, you sort of scratch your head and figure out what it is. Nowadays, you sort of like say, yeah, this is what it is. We'll jump in the middle of whatever. We'll talk about that. So relax, and this was it. This was one of the things, 1998, but it's really, non sequitur. Sleep study, relax, go to sleep, pretend we're not even here, sleep research, okay. And that was really what we did. And people sort of like laugh, cry, do whatever they want to do. 1993 to 1998, Wisconsin prevalence was published in the New England Journal of Medicine. It was funded by a SCORE to the National Center for Sleep Disorder Research. There were 3 of them, we had 1. Same order of magnitude as diabetes. Now, there was an editorial about, oh, this is pretty common. They didn't sit there and say, it's as common as those 2 diseases. We should probably have an infrastructure as common. It's like all those diseases, asthma, diabetes. And you're just starting to see that. I mean, direct to consumer, all sorts of things going there, therapy all over the place. People kind of going one way or the other. I got these apps, I got these things, pay me some money for this. I'm going to get all these things, breathe right strips, all these sorts of things again. And if you sit there and you look at what they have packed around diabetes, that should be what we pack around. That's what we're packing around OSA, but that was predictable at that time. It was interesting. The exuberance of epidemiologic data, not on clinical outcome or perception, but there was an entire exuberance. So it's everywhere, and that was in 1993 to 2000, right? Of course, there's pushback for that, And the most common, the thing that was the most devastating is that I don't know if you guys ever learn about clip murmur syndrome? Look at this. We got people here, Sushil, that are shaking their head saying, I've never heard of it. Clip murmur syndrome.
Yeah, long time. Haven't heard it in a while.
Yeah, why not? No. Clip murmur syndrome in the 1980s and 1990s was a condition which was predominantly in women. It caused fainting, and it was a little bit of a flow murmur on mitral valve, and the mitral valve was a little incompetent, and was thought to be an autonomic nervous system sort of thing, and it would produce sort of fibromyalgia and this sort of thing. But it also meant that if you thought you had clip murmur syndrome, you had to have a $450 echocardiogram. So Blue Cross Blue Shield of Alabama said sleep apnea is the clip murmur syndrome of the night. Everybody had to have a sleep study, a very expensive test, and you don't know what it's going to do to you. So it was sort of interesting, these sorts of things that go through. No, you don't hear about clip murmur. You don't even hear about Brady-Tacky syndrome anymore because that's bad. So then there were some early studies. This is out of Virginia. The automobile apnea. You could have automobile accidents, and severe sleep apnea would increase your risk of accidents per driver per year. if you're really being a data driven person, you say that well, sleep apnea protects you from
That's right.
it. That was all drivers in Virginia, all drivers in Virginia. Okay. So evidence on car crashes. 50% of all sleep apnea patients have never or will not have a car crash. So when people say, I want to ban driver's licenses for all people that are designated sleep apnea, that really is not it. Clinical cohorts, the risk of a false sleep crash increases when the AHI is greater than 60. That was from Pennsylvania. They had the first group of about 300 or 400 people asked them about car crash. And everybody said, well, they didn't really ask. They asked them, they didn't, but they weren't honest, right? Patients aren't honest. They're terrible. They won't tell you. Maybe 90% of them were honest, so that's good enough. And the community sample, sleep apnea is measured by AHI, effect is confounded by obesity, sleep restriction, comorbidity. When I went through this state on car crashes in OSA, depression, hypertension, cardiovascular disease, all increase the observation of a crash by 1.3 when controlled for all other variables. And so, you know, you sit there, we see people with those things as well. And depression is really, that's off the chart. Insomnia is associated with hypertension. So then the hypoxemia. Well, this is a record that we did in 1998. We could take a battery-powered recorder and a battery-powered oximeter and put them on someone and record for 24 hours. We did that on a bunch of people. And in looking at this is the 24-hour record. This dotted line is about 99% or so. And you can see that there are these periods of time in which there are decreases in oxygenation that occur here in the afternoon, here it's 11 o'clock at night, here it's at 3 in the morning, it's a good break, and then we sleep again, and then this. So. And then this is cumulative percent. So this is 100% up here, this is 0, this is 75, and this is 100%. And these dotted lines are the normal values of a mean and 2 standard deviations in a bunch of like 40 people, including with the lowest oxygen saturation being about 80% here. So here's the confidence limits for the lowest. And why is that? Because people go into REM sleep, have an apnea, they will want by whatever it is, it's called. So lowest value, which you guys do. Now it does correlate, the lowest value and the 20% time value do correlate. But you know, I still don't know why people just talk about the lowest value, because that could be spurious, it could be all sorts of things. They all like, oh my God, it went down to 78%. Well, went up to ski and Dale, it would go down to that value almost every. So we had 20% time, then we had hypoxic stress, intermittent. And the other thing is, we proposed that sleep apnea was not just the values that you had between hours of conventional pulse and hypopnea. The sleep apnea severity was whether or not it broke through in the daytime. Right? So it was the idea that the more and more hypoxic opportunity that you had, the more and more opportunity for sleep fragmentation, even if it was under refreshing, that was there. I don't think that's true, but we could speculate that. I just call it a discussion section. I put stuff in discussion sections that I say, oh, okay. So then we had a model here. We had the cardiovascular OSA model and what it could do. So, you know, when you got this hypoxemia, you got sleep disruption, you got hypertension, you got this, you got to put all these boxes together. And smart people took hours putting these things together, right? On the basis of very little data. But you could say, okay, repetitive apnea is enhanced sympathetic activity, hypoxic stress, hypercapnia, pressure swings in the thorax, oxidative stress, insulin resistance, inflammatory responses, and endothelial dysfunction. And that was a This was a model that I should have put the date on it, but this was sort of like 1992. So what else are we talking about today? Well, we're talking about nuances, measuring inflammatory mediators, and we find them, but not everybody does. We measure, other things like platelet aggregation, and they found it individual studies of 20 people, 40 people find this, but they don't, but they conclude that it's elevated. And when you look at the data, the individual data, you find, there's people who don't have sleep apnea are elevated. And generally it goes with the severity of the illness. But and then you try to treat it. So how do you treat them other than CPAP? And some of these things that went down. But is it the sleep interruption? Is it the hypoxemia? Is it better sleep? Is it whatever it is? You don't really know. But you measure these markers before and you measure them afterwards, and you go, see? And you go, what do these markers do? Well, they're found in heart disease patients. And you go, oh, okay. And these people don't have heart disease. Oh, okay. So what do you do with it? Now, can I use it with drugs? Well, it turns out statins are pretty good at reducing inflammatory. It's cardiology literature, statins all go by. So everybody's on statins. So that's one of the reasons it's hard to find zero. Everybody's on statins. You'd like to go out to, and there are some really interesting longitudinal studies coming out of South America where you don't have a lot of drugs. So now you've got big groups that want to do it. So that will give you some ideas. And there is some things that in China as well. So the physiology hypothesis. So how do you get to 30 apneas per hour of sleep? Well, you genetic predisposition, food availability, you get your upper airway, whatever it is. You get fat deposition, you have an abnormal upper airway, you have more apnea hypopnea index, you get more neuroexcitatory state, insulin resistance, you gain more weight. And you rinse, wash, and repeat for 5 years. Because it's out in the old roots. So that's maybe how you get to that point. So that was a model that we measured things. And then this is a classic one that came out of 1992. Population risk, mild, moderate, severe, hypoxia, sleepiness. So it's great. It's actually responsible for drugs trying. The less people are severe, the moderate, the less people are moderate, that are mild, probably this population at risk. I heard these guys talk about it. I don't take credit in terms of being, a guru on this. I just heard the data and said visually this is what it looks like. But when you think about it, how do you go from population at risk to mild to severe? Do you do it in a linear progression? Or do you do it sort of like, if I'm going to have sleep apnea, I'm going to jump to some sort of disease category because of my responses, glucate responses, sorry. So you have to sort of say, when you see this patient, how were you 10 years ago? How were you 10 years before that? What sort of things change? And maybe there's a prevention to that. And I propose risk grouping for low, medium, and high, in which the instruction for low risk grouping, which didn't need a test because at that time it was a PSG, lifestyle, exercise, increased sleep, and assessment. If they were asymptomatic, restored, they didn't have much, medium, reduced sleepiness, check cardiac risk, and follow up in 1 month. High, treat, test, right? So what do we do now? Oh, you snore? Sleep study. You look bad, sleep study. Yeah, you're big, sleep study. I mean, the sorts of things you see, especially from the HS. So now from 1990, it was recognition, assessment. You could observe, but that was rarely your use. You could test, and then once you tested, you could assess, and then you could treat, and that's because of mild sleep apnea and have symptoms. And then outlook, and then the thing was, everybody said, oh, that's fine, but what's the outcome? And what that was, and what was what's the outcome outside of a controlled trial? That is somebody sitting there having a fellow, 3 fellows, call up all these people, examine them and follow up, put all these numbers together. What do you do in the clinic? How do you figure it out? We really haven't done a great job of making that. We do it individually and it's center-based, and it's sort of like states' rights versus federal rights. I mean, the federalist system in sleep medicine is the accreditation of sleep labs, right? And yet, the states' rights are every sleep lab can come, and they give parameters for what you have to do. But every sleep lab can do it sort of their own way, collect their own data, and don't have to put it back into. We need a sort of a national AASM clearinghouse for numbers. Privacy, all this sort of stuff. Yeah, and what, we got the cloud now? There's stuff in it? Yeah, okay. So management 1998 to present, emphasis on randomized controlled trials, because in 1998 there was a report, a Cocker report that came out of, said you hadn't done any randomized controlled trials of CPAP, so it's worth it. So people had to do that. Oral appliance, emphasis on pre-test probability and patient stratification for severity and development of pathways. So 1999, auto titration, or treating while you test, or testing while you treat, or whatever it is. And we still patient-based, limited to CPAP, increased uncertainty, comorbidity, feasible. So what do I mean by increased uncertainty? Well, you sit there and you get a history. You don't really kind of know what flavor their sleep apnea is, mild, moderate, severe, and you sort of treat it with this. And you sort of say, I think that's what you have. And unfortunately, their primary care doc promises them they won't have to go to that nasty old sleep lab study. But what you have to do is they're saying, this is what we're going to try. You have to learn how to use this. You've got to be able to struggle with it a little bit. You have to figure it out. But that doesn't mean you won't ever go into the sleep lab again, because then if it comes back and I find that my carbon is, I don't know, 40 or something like that, they have to do something a little different. That's the unusual case, but those are the things in which you have to sort of manage expectations for what this thing will do. And that's part of what you've been experienced now, managing those expectations. And that's why you ask them, you know anybody that has CPAP? Sit there and go, oh yeah, they hate it. And you go, oh my goodness. Oh. But on the other hand, they sit there and say, oh yeah, my brother has it, he really loves it. And you sit there, okay. We're fine. We're figuring it out. We'll work on this. We'll creep on it. We'll see that you haven't. So now you test and treat, and you have an outcome. So no matter do you test here, you test and treat in some ways doing it. Imagine if you had a CPAP machine. You sat home and you said, I don't want you to put this mask on until the second night. But the first night, I'll remote up your little oximeter, your lubrication level motion. You can do it, boom, boom. So far, the testing and the CPAP people together have not really gotten it together. ResMed has, at least at one time, they had a place that you could plug in an oximeter. But that was primarily in their high-end bio treatments. So that's for stroke ACI. And then you could squirt it up to the cloud and you could look at it and see what it is. And your pulmonary fellow can adjust CPAP where the pressure is. That's where. So for clinical outcomes, the first was AHI, O2 SAT profile, blood pressure, patient-based treatment itself, and effects on sleep and quality of life, and cost-based direct and indirect patient. These are the sort of clinical outcomes. You notice that's 1998. That was conference on outcomes for sleep apnea included, but it was also created a sort of severity index, but so it had to be called research because people didn't want to preempt anybody. The clinical decision until Medicare came out with a consensus, or at least wanted to have a consensus statement. They came up with this 5 to 15 symptoms, 15 or above. You don't have those. But really, the patient is worried about this cost, all that sort of stuff. You have to realize that's what they don't really. First of all, you have to explain what an HI is. That's always. And then you have to explain, what do you mean by O2 sat profile? Oh, I get one of those. Why can't I just get one over there? CVS. Well, it doesn't record over time. Yeah, but I wake up and look at it.
It says 98.
It says 98. Or it says 86. That's all I know. And then when you sit there, you say, okay. So you hold your breath below an oxygen saturation of 90%. And then you relax, take a breath. How long does it take to get back? It takes 30 to 40, 50 seconds, depending on the average time of the oxygen. Remember, if it did it every beat, the thing would be going, 98, 97, 98, 96, 95, 97. But if they do it every 10 beats or every 30 beats or every minute, it sort of comes out there. And what do they do? That's why it's always great. They call you, nurse call you. The saturation is 86%. And I said, well, what's he doing? He's talking to me, he's doing this sort of thing. Well, how'd you know it was 86? Well, the machine told me it was 86. Well, when did it? Was it awake or was it asleep? Oh, I don't know. It's there, and it's now okay. All right. So CPAP and patient outcome. Theory is one thing. So that was pressure goes up, normal breathing, how you can do it, whatever it is. This is the first. It's interesting if you got time to go back and have the first descriptions of clinicians telling other clinicians what CPAP is all. That was really interesting because, Sushil and his group there, me over here, and other people go, it's peak crit. And they go, what's peak crit? Critical closing pressure, what's that? But for a guy that's sort of struggling to treat patients and wants to understand his primary care doctor, how do you explain this? And they would say, well, it goes up and down, changes pressure according to what. That's auto filtration, where you change. It's interesting. So coordinated management, patient-centered assessment, education, and technology. And there was what do you think was the first emphasis? Technology, right? So the first auto titration machine was out of a company based in New York. And you should ask Carl about it, because Carl heard about it. And for the next 10 patients he ordered, and all of them came back within 2 months and said, this is terrible. This is really, because it would detect an apnea, and then it would try to force the airway in. Right? It would make it. Right. Boom! Hey, what the heck? What the heck is going on here? They were used to their apneas. Now they weren't used to this machine. So then there were some other things. And then what you had is the auto titration that came out of ResMed was the first one that sort of went out there. And Respironics put one out there, but it was just as bad as the other. And one of the people I mentioned, Tom Thoreau, was working with computer program one that was there. But if you go to these, if you go to the annual meetings and you listen to ResMed, they'll talk about one of the people in there, one of the MD programmers, and then they put his brain in the auto titration machine. It's very interesting. We haven't lost it now, but we did a study for respiratory eyes when they did their approved version of it, and we did one night in which the titration was by a technician, auto titration, and it changes. You can't read it like you do a usual one because it changes every 15, 20 breaths, but it doesn't change by very much. The original ones were changing a lot. They were just, they really changed. So then we worried about compliance, and then we didn't like compliance. We called it adherence. Both indicate the amount of time the patient uses it. The chronic goals are greater than 60% compliance rates in general now. Why is that? Why is 60%? Well, it's a chronic disease, right?
And they use the machine for quite some time.
Yeah, but you're thinking too narrowly. So how often do patients take their rheumatology meds? How often do they take their hypertension meds? How often do they take their inhalers? How often do they do these sorts of things? And CPAP is pretty good for that. And so, we beat ourselves up when it's more than it's less than 70%. Especially if people are established and go off. But that's the reason. So the people who are really, see, the other thing is we really haven't had, the group that talks to us is not the people that are the macro, I'm going to take care of the population. And what are the issues you want to have? The hypertension works, it protects people, generally because people take their medicine 60 days. Now, the problem that you have with CPAP is that you have to buy it up front, right? And whether it's 90 days, but it used to be kind of like 30 days, or whether it's you pitch in money for a year and a half, you buy it up front. It's not as though you say, I don't have enough money for my meds, so I won't buy it this month, or oh, I forgot it and I'm away, I'll do it. So it's not a recurrent monthly cost, it's a big hit in terms of that individual's health cost. And you can see how companies try to put it into the DME pit, right? This is more like a wheelchair than it is like a daily therapy, right? And we have to push back on that every now and then, and it's hard because once they're entrenched in this is a wheelchair, DME, then how can I get the cheapest wheelchair delivered by the cheapest vendor, by the cheapest person without any instruction, right? Okay.
You're saying that for our compliance requirement was not quite arbitrary, but
Yeah, it was a consensus. Somebody sat around and said that, and Medicare picked it up in the companies.
Wasn't that a minimum number that led to an improvement in the efforts? This 70.
Oh, yeah, anybody ever use that?
I think Dr. Shaw mentioned something.
Yeah, but no one uses it
No.
across the country.
Yeah,
Those are the individual things. Those are the sort of local rules. That's the state rights. That's the center rights. We want this. And there are studies you can find that the minimal improvement of the Epworth scale should be about 1.5 to 2. On the other hand, there are studies that have sat there 3 months after initiation of CPAP therapy. You sit there and you get their Epworth and you say, oh, here's this nice number. You remember what you were like 4 months ago? Could you do your Epworth then? And they'll do it. And then you look back 4 months ago, and actually they're retrograde. They're worse than they were before that. So it's a really tough call.
Yeah.
It's a tough call to do because people really have learned to live with their sleepiness, their sleep apnea, their symptoms. Recall bias. You say, well, that's all recall bias. it seems right, that's why. Oh. So, inclusion criteria, parallel, either gender, ODI, et cetera, so interventions. So that was nice. High level of compliance with the literature may represent selection bias for studies. Really? I mean, people that want to try this machine will have a better reason to use it, and that's right. Or is that good? So maybe we can just say you want to use this thing, right? But this was sort of said, oh yeah, it's over. It's over. Yeah. Those hypertension meds, you know, not as good as they really seem, right? Humidification may improve adherence. There's really no data that suggests humidification, but everyone puts humidification into these because practically one person, I know the person, Nikki Netzer in Germany, put it into a machine, tried to sell it to Lyman, so they didn't want it. And within 2 years had an in-machine humidification system. And, ignored the German patent, and there was no international patent. And so everybody put it in. Because previously you had to buy your CPAP machine, and then you had a Fisher pipe kelvin meal. Bi-level should be considered in patients with difficulty starting treatment. Some studies came out and said there's in groups there is no difference. There are individuals that like it, but you often hear people say, well, they don't like CPAP, let's try that. The data are, current evidence does not justify the use of auto-titrating CPAP in unselected patients. And this was the conclusions in 2004. Evidence for educational interventions is too preliminary to allow cost benefit of this intervention. So what's the best educational intervention? It was determined, and it wasn't used generally. There was not a huge number of studies there. So you've got a bunch of studies where they give them a machine and give them some instruction. You got a bunch of studies, you give them the machine, give them instruction, you talk to them about weekly intervals without doing any other things. And then you got this sort of thing. It's called a CPAP coach. And it's sort of like their exercise coach. It's an individual. And so they, I think it was Denver, they got a grant. You're this guy's CPAP coach, and their adherence went up to like 85, 90, 95%. Because they would detect it very quickly, they would adjust things, they would motivation. So those are the things that are there. Psychological and social issues in compliance. Compliance largely determined in the first days to weeks of treatment. We don't do a very good job of that. Best people to do a job for that are those private sleep labs and sleep centers, which issue their own equipment. And so at 90 days, if there's good adherence, they get paid the full amount. Well, about 6 years ago, 7 years ago, one of our fellows went up to Minnesota to a group like that. And I kind of knew about it, I had asked a lot of questions. And he briefed it. He said, yeah, they have 3 full-time respiratory therapists. And they had 16 beds. And the 16 beds were filled 6 days a week. So you can sort of do the math that for them to have 3 full-time respiratory therapists seeing these people through the first 90 days, that particular cost of those therapists were sufficient for them to hire these people and put out the machines and have the machines painful. Did they care what happened on day 91? Absolutely. Technology improved compliance, just small groups, humidification maybe, CPAP versus auto titration, no. Nasal oral face pillows, no. Individual patient may improve the underlying issues. Self-efficacy, that is the person's willingness to control. C-flex technology, that is the expiratory reduction as you breathe out. Compared to conventional CPAP can improve adherence in 3 months. That was highly studied. Clinical outcomes are not consistently better if C-flex users are more confident about their ability. So that's probably something. So the next step is big, really big data. And the anime is doing this. So worldwide, 1 billion patients. There you go. 15 million PAP machines with cloud-based. That's cloud-based data. VA database issued a CPAP machine. Life expectancy has increased 5 to 10 years in those less than 55 and over 50. And everybody goes, well, were they using it? You know, I don't know. They were just issued the machine. And you say, well, those issued the machine were sort of said, well, they wanted to get their health improved, they want to do this, they probably had a better sense of what they wanted to do. And some VA doc said, yeah, okay, I'll push.
So was this in comparison to patients with sleep apnea who were not issued sleep apnea?
This was all cause, and they had those people as well. They had OSA diagnosis, which was uncertain, as well as.
But this is just the general.
Remember, this is sort of like the VA database here. Is you've got the entire VA database at your control, right?
Yeah.
So whatever small variations are there are washed out. So if you're 55 and you're male, you can work on all those data and adjust for it. You can do that. And then one of the adjustments was, do you have a CPAP machine issued you or not? And then do you have diagnosis on the second, right? And then you just crunch it together. And I think there were like 8 million people in the VA system at that time. We have 12,000 machines that are currently out there working. We probably issued about 20,000, 25,000 from the last 10 years. From just
Why did they make 55 and above?
because there wasn't enough older people would benefit as much as young.
Couldn't say all comers.
Yeah, they could. It was a similar. I think it was like eight years for under 55. But it was surprising that even when they went up to even 70 years of age, and people were really surprised by that. And then they picked it apart because it was a huge database, right? How do you make an individual decision that's going to do, whether they use it as a doorstop or they use it every night, doesn't matter. So the VA database, and this is the guys in the Zincheck did New Haven, Cleveland, Indianapolis, was able to kind of get 1,500 to 2,000 sleep studies that were done between 1998 and 2003, and that were scored on a common basis. So they rescored all those studies using kind of modern rules, and then they could follow those people forward because it was done and they were looking at that. They looked at mortality and they looked at morbidity and disability and mortality, and they found that it was not age. That it was a metric that included things like sleep disruption, arousal thresholds, all sorts of other things. That was after control for all sorts of things. So it's not AHI by itself, it's something else going on. Now, admittedly, you don't know where people are in their course of their sleep apnea. Since there is no acute sleep apnea, there's only chronic sleep apnea, and you pull them out of the prevalence pile at different stages of whatever they do, like 10 years, 20 years, 30 years, 40 years, and with different degrees of comorbidity. So what's the future? Various models of delivering care. These are medical systems, risk management, diagnostic clustering, There's now a symptomless OSA estimator for Epic. Resource utilization, that is how many docs do you need. Resource needs, healthy workforce for companies, nutrition, exercise, and sleep is becoming pretty important. Progressive has a program for that. And you want to detect preventable causes for errors like truck companies that have sleepiness. Tread on new ground. All sorts of things, right? So you'll find all sorts of commercial models that will come in your trucking company profile, risk group, task tree, behavioral, whatever it is. You'll find all these things. And because new truck driver's licenses in Ohio is 300,000 per year. Now, most of these, not most, but some proportion, a good proportion, are people that are getting their license for a second time. So how long is the average job expectancy in a long haul truck driver? So for you, you're a doctor, you say, oh, I'm gonna work for the next 4 years. That's what you say, right? And you're assuming when you look at somebody, oh, they're gonna work for this. The truck driver in Ohio is about 18 months. And after 18 months, they kind of say, oh, I hate to be on the road, wife's getting this, whatever it is, want to do it. So they go out the system and then they try something else, they don't get enough money that way, and they get back to the system. So you have to realize what these occupational things. The sleep center is going to have certainly procedures, sleep consultation, management, teaching students, and I put research in because that's the R word, and no one really, that's a doctor thing, that's not a sleep center. That's what would be a doctor. So then, community health, chronopharmacology, collaborative clinics, and patient-based diagnosis. I think that's an interesting area. One of the guys here that was here as a sleep center director, briefly, because they just drove out of town. Put his sleep center right in the middle of the neuromuscular. Got a room, neuromuscular clinic, neurology patients, right there. And fed 30% of his practice. Right? And you go, why? Because, do they really need a sleep study? But they have a sleep doctor there that says, what do you think I should do about this person who really has got progressive muscle weakness and say they have a little short breath? Well, it could be because they're not breathing very well. Huh? Oh, but yeah, that CPAP is so tough. I'll take care of it. Not a problem, right? So that's how you do it. So maybe center will be rewarded based on patient outcome and prevention of sleep. So that's where they're going with dermatology. Dermatology, they don't want to have, and that's threatening to the dermatologist. So when you mention it to them, they say, well, we're becoming more specialized, which the reason for that is they want to be able to be specialized so that they have to see the patient rather than take a picture, right? It used to be they would see the patient and say, oh, now you can photograph them. Oh, okay, that's that. So, but they're going to be paid not because they see a patient, but because they're able to prevent malignant nevi from being more than grade 1, right? Be like the colon cancer. You don't want people to present with stage 3 or 4. You want stage 1 or 2. You want to detect early. You want to be able to do that, and that's really how you're going to pay the system. That's the worth of the dermatologist is to be able to do that, and that's hard because you're paying a doc to see patients. You don't get paid to prevent disease. Center will higher level of operations and a greater diagnostic complexity. We've got it, I've been talking about this for a while. 128 electrodes a day to replace an MRI monitor for 8 hours with complex cognitive difficulties. And then there'll be independent time and space. We've already done that. Institute of Medicine, and they said, well, how do you really put it together? This is an old report, 2006. They proposed an accredited interdisciplinary sleep program in academic institutions be the level. And I drove people crazy, but their model was that of the cancer center. Cancer center doesn't really, is transdisciplinary. And it's, you know, if you're prostate cancer, you're in one department. If you're breast cancer, you're in another department. If you're GYN oncology, you're in another department, but it's still a cancer center in terms of trying to figure out how to. So, but OSA is a model. So clinical management focused on outcome. So anything else? Which do we want to take on? We want to take on insomnia? We want to take on RBD is not a big market, but it's probably not being diagnosed out there. Narcolepsy is bigger than you think because it's a spectrum. It's not diagnosed out there as much. And other sleep disorders will follow suit. So it's a good model. So that's what I think.